My talk is on Barrett's Toric calculator, but I should mention this. The EVO formula and the Kane formula in some of the most recent publications are supposed to be slightly 5 to 10% better than the Barrett's Toric. So this may become the future. As of now, I'm not using them. I'm still using the Barrett's Toric. Now, there are various versions of the Barrett's Toric calculator, and they are updated once or twice a year, and the updates first appear in the APACRS website. The older versions are found in company calculators like the Alkane Toric calculator, in the IOL Master 700 that some of us have, or the Lenstar that we have. So we have the older versions because of delayed offline updates. We don't update our offline calculators. And also in the online calculators for like the Alkane, FDA regulations make it difficult for them to make changes in their site once or twice a year. So this is available. The Barrett's Toric APACRS is available online. It's free. Here's a home page, and there you have a drop down where various formulas are there. Barrett Toric is a variation of the Barrett's the Barrett's basic universal 2 formula. So this is I have put the same data into 2 calculators. One is the Alkane Toric calculator, and to the right hand side you have the Barrett's Toric calculator. They give very similar results. Both are asking me to put a T2 lens at an axis of 90, but please note the calculated residual astigmatism in the Barrett's online calculator is 0.07, while the Alkane calculator is giving me a 0.17. What happens is once in a while it will bump up your lens or bump it down. And so it is better to go in for the online calculator. There are 2 things which is of great use in this calculator. One is the K calculator, which helps you to calculate the integrated K. And here you have another option, the predicted posterior corneal astigmatism, which Dr. Atik so beautifully showed is if done with the measurements are good and you have a good intraocular lens, 88% of your patients will be within 0.5 diopters post-op. Or you have the measured posterior corneal astigmatism, the measured PCA option. So if you choose the measured PCA option, you'll get a very simple drop down like this. You can enter the data from one of these 5 options: IOL Master 700 True K, the Pentacam, GLID, OptoView, any SSOCT device or any Schleim plug device. You can enter the anterior, and the posterior, steep, and the flat K. That's all you have to do. So this is the measured posterior corneal option, which is useful in post-classic eyes, where the relationship between the anterior and posterior cornea has changed. It's also useful in ectatic corneas and thin corneas. It is not useful, like Dr. Atik mentioned, it is not useful for our virgin eyes. For virgin eyes, please use the integrated calculator. So this is the K calculator. You put in the data first, then you press K calculator. It gives you the option of entering data from 3 different sources. We know that the same eye, when measured with different kind of instruments, will give you different K1 and K2. So here we have the option of a topographer, IOL Master, Lenstar, Pentagam, Aladdin, Argus, manual, as well as auto K. You can take a choice. Then you can calculate and get an integrated K. This integrated K is then used to calculate the PCA, which the calculator will do posteriorly, and then it will give you the final calculation. So in summary, the APACRS calculator is the latest version. Every other version that we have access to may be a little older. The integrated K calculations are possible with this Barrett's calculator, but not with the Kane and the EVO calculator. Please use the True K function when you have ectatic eyes and in post-classic eyes. That is in summary. So I come back to the Kane formula. There is a beautiful review article last year showing it is far superior. In 10% more eyes, you will be able to get within 0.5 diopter. You have the non-toric, toric, and keratoconus in one simple option. This is the Kane formula. LRIs are an option when the patient cannot afford to have a toric lens implanted. Please go online and then type in LRI calculator. It is maintained by the Johnson & Johnson. It is free. They don't own the software behind it. So I use the Donenfeld nomogram. I don't use an APA. So once you enter the K1, K2, and your SIA and the location of your incision, you'll get a beautiful picture. This is a picture of the face. This is the right eye. We are making a temporal incision. In this particular example, it's asking me to make a 70-degree nasal LRI, which you can do with your diamond knife. So this is as far as LRI is concerned. Why do we need customized toric IOLs? Toric IOLs, generally the library which the companies maintain, extend between 1.5 and 6 diopters. And so when you have a patient who needs a higher power, it is still possible. Zeiss, IOCare, Apasami, and many others will make you a customized toric lens to order. And this can give you fantastic results like this example from Dr. Arumarivarman's practice. So this patient is post-ICL, 10 years ago he had ICL. He had high myopia with a bit of keratoconus, now needing cataract. You can see that he has axial myopia, and you can see that he needs 3.83 corneal cylinder. And using the ZCal, it shows you need a 7-cylinder high-powered toric lens. So here, Dr. Arul has put in a trifocal toric lens in this patient based on this calculation. And this patient had post-op uncorrected 6.6 to start with. Dr. Arul has a small group of these very exceptional patients. So anybody in the audience who has a similar situation in the future, please contact him and discuss your calculations with him, and you too can get these kind of fantastic results. There are after you do your calculations, there are two ways of marking the cornea. One is a direct manual marking. The second is using an online marker. Both markings will give you good results, like in this study done by Dr. Ramamurthy et al. Published in IJO December 2020, and he found they were equally effective. A systematic review of image-guided lens extraction surgery found that when you do online marking, or if you do a digital marking, you will get a 2-degree more accurate marking. So there is a advantage in going digital if you have the volumes. So with the manual marking, you can get results like this: T4 first post-op day 6.6, T3 first post-op day 6.6 partial. Here you implanted a T6 first post-op day 6.9, no improvement. So how do you do a manual marking? Use a very thin slit. Move the collimated dial on your slit lamp till you get the correct axis. For this patient needed 4 degrees. This is 0. This is 5. This is 10 degree. So 4 degrees is slightly short of the 5-degree mark. Then use a disposable needle. Apply Paracane and directly mark on the patient's cornea before surgery. This can be done by an associate on the OP or by you before you take him up for surgery. And you can get these beautiful results by doing manual marking also. Many of us in India have started doing this manual marking.